Grab your onions, Protrusive, because this podcast will change the way you think about a pulpectomy. You will probably do way less extirpations and committing to a root canal. And this episode will really challenge our beliefs that we hold in terms of what requires a root canal treatment, i.e. we were trained that irreversible pulpitis equals pulpectomy, which is a root canal, right? Now, that's what I was taught too. But what is happening now in endodontics is brilliant. And George explains it really well with his lovely German accent. We go over the fact that nowadays, whenever a patient comes to George with irreversible pulpitis, that severe throbbing ache, it does not mean root canal for him anymore. It means a pulpotomy of the permanent tooth. It means a pulpotomy of a vital permanent tooth, which then hopefully will preserve that radicular pulpal tissue. And therefore, the patient will not require a root canal treatment anymore. So it's pretty different. Now, maybe you're already seasoned in this. Maybe you're already using MTAs and whatnot, and that's amazing. Good for you. But for a lot of dentists, I imagine this is like, wait, what do you mean? We don't have to commit to a root canal anymore. Like we can actually do a pulpotomy for an adult, let alone one that we have diagnosed as quote unquote irreversible pulpitis, which actually George argues is a poor term. Welcome, Protrusive. I'm Jaz Galati. I'm your host. And if you're new to the podcast, welcome. It's great to have you. If you're a veteran and you've been with me for many years, it's always a pleasure to have you. This one's a really cool episode. I didn't think before I recorded it that I would be having so many moments of laughter with our guest, Georg Benjamin, who, whilst not a specialist in Germany, he is pretty much limited to endodontics, and he's been following vital pulp therapy or pulpotomy of vital adult teeth for a long while now. And he's got some great views on it. And if you listen to the end, we say some very controversial things about certain groups in dentistry, so I apologize to my friends if I offended you. It was all a little bit in jest, but a little bit serious at the same time. The protrusive dental pearl I have for you today is, and I'm really hoping I haven't shared this one with you already before, but it is, how do you test for objective anesthesia? So as you know, guys, I'm a big fan of buccal arcane infiltrations for lower first molars and even lower second molars. If I'm doing a root canal or a crown or a large restoration, I am no longer reaching for an ID block. I am doing a buccal infiltration with arcane. I've got a video on YouTube showing exactly how I do it, and I get about 90% success rate with this. And I say there's easy patients and then there's difficult patients, the difficult ones being the thick bone and whatnot, and yeah, probably success is 80% with those guys. But more normal anatomy, then I'm probably getting 95%. So if you balance it out, it's about 80-90% success rate. And so one thing I started to do to really make sure my patient is super numb is, instead of subjective, instead of asking the patient, are you feeling quite numb? Is that really numb? It's much better to be objective. So I get some endofrost, so minus 50 degrees on a cotton pellet, and I put it on tweezers and I press it onto the tooth and I leave it there for about 10 seconds. And hopefully the patient will feel nothing at all. Now that, for me, gives me so much more assurance that that tooth doesn't require a supplemental anesthetic. It does not require an inferior alveolar nerve block. And that's worked really well for me. So in those times where I put the cold on, and after about 6 seconds, they say, I just feel a little bit, I'll either give a little bit more arcane into the gingival tissues, subperiosteal region, or I might even, in a tricky patient, give an ID block at that stage. So it really helps me in my decision making. So next time you're not sure, do a objective test by putting endofrost on the tooth and just seeing the response before you start your therapy. Now, by this point, usually I already have rubber dam on, and it's the last thing I do before I then continue my treatment, because most of the times they won't feel the endofrost anymore. This episode is brought to you by Enlighten Smiles, the good guys, Payman Langrudi et al., who support this podcast so dearly. Thank you so much. I love using Enlighten Whitening. I'm getting great results from my patients. They got some awesome trays, and their gel is always fresh. And of course, if you want some training, you have to check out the 1 hour webinar that Payman does. As always, it's in the link section. It's also on the YouTube for the freemium version. And if you've not already downloaded the app, the Protrusive app, oh my God, we're getting so much traction. We're getting so much good vibes on the community section, and the exclusive content is just gonna blow your mind. The amount of things I've got planned for it is gonna be amazing. So if you haven't downloaded Protrusive app yet, what are you waiting for? Download it. Let's join Georg Benjamin to discuss vital pulp therapy, aka pulpotomy, for adult teeth. No more irreversible pulpitis. Georg Benjamin, welcome to the Protrusive Dental Podcast. How are you, my friend?
Oh, I'm fine. Great to finally be on a different podcast as well.
Well, for those who don't know, George is a host of his podcast, which is mostly in German, I believe. Tell us, you've been podcasting way longer than I have. Tell us about your podcast in Germany and what kind of topics you cover.
Basically, I started podcasting in 2016, which is now basically ages ago. And actually, I remember in 2018, everybody in the podcast environment was talking about, oh, we reached podcast peak. It's over now. It won't rise anymore. And I was basically inspired by the Dental Hacks podcast, basically the American podcast, which is now a very dental podcast. They're kind of split up, but Alan Mead is still doing it. And I was kind of surprised how Americans talk openly on their podcast about certain things like, oh, well, I got everyone in my team an iPad. I mean, they're just $1,000, so I got 10.
Sounds like a very American thing to say.
Yeah, things you would never hear on a German podcast. It was like, yeah, talk to my tax advisor, and after that we found a way to make it work. Yeah, well, at least my podcast is called the Saure Zähne Dental Podcast. Actually, the name wasn't very SEO anything. We just started enjoying the dental hacks and started our own podcast, and actually we were the first German dental podcast for other dentists, and it's a really good networking tool. I mean, who should I tell you that? I saw how you grow with your podcast. You now even have an app, which is really great, and the networking part is so good. I just can encourage everyone to start a podcast. Today there are so many podcasts on how to start it and how to present yourself. I started just without anything. I just started without a name at first and started recording. It was so much fun. I can really recommend it to everyone.
Amazing. For those who want to listen to a German dental podcast, check out yours. I can't even pronounce it, but it's amazing that you are so dedicated, and I'm sure every dentist in Germany probably knows your podcast. Today we're going to do this in English, guys. Don't worry, be reassured. We're going to do an English podcast today on vital pulp therapy, as you in our preamble, our pre-chat, you described as vital pulpotomy for adults, because dentists are more likely to be like, oh, okay, I can visualize what that means. So before we get into that, just tell us a little bit more about yourself. Are you limited to endodontics? Are you an endodontist, or do you just love endodontics?
It's very interesting. Basically, in UK terms, I'm a general dentist, but I spend most of my time with endodontics. That means now I recently opened my office. I have a scope, a CBTC, so everything you need today for endodontics. But actually, when I graduated in 2010, I basically didn't have any, or when I heard this term pulpotomy of teeth, I was only thinking about milk teeth and never heard about anything else. And it was really interesting. When I was a young dentist at my first dental job, I was in an office in a rural area close to Berlin, but there were like 2 dental offices in a town of 10,000 people, and we had so many patients. It was crazy. I mean, after 2 weeks, all my afternoons are already fully booked. It's like the best start for a young dentist. And they had an interesting approach to pain treatment if someone came in with a irreversible pulpitis. And the pain treatment was basically very simple because we didn't have a lot of time. It was a full pulpotomy. And we basically just placed a cotton pellet on it with Ledermex, which is like an antibiotic steroid mix, which is very popular in Germany, and covered it in Kevit, and recalled the patients on the next day just to see if they're fine, if we should need a root canal treatment, or if the whole thing brought us time. And actually, it surprised myself a lot how much time this actually gave us. And when we started to do the root canals later on, it was quite usual that the pulp was still vital in the root canals, and it was basically we had to do anesthesia, rubber dam, of course, and it was pretty much standard endo. And I was always chatting with my boss back then. It was Dennis, how come if this pulp cells in there are still vital, we need how come we can't place anything on it like MTA, so we don't need to do the endodontic treatment? And back then it was like, if it's an irreversible pulpitis, it's no way out completely. It's a one-way street. And this is how
which George, that everyone who's listening so far, I mean, not everyone, but I'd say 98% of our colleagues, the Protrusive listening right now, probably think the same as what I thought as well, which is when you diagnose irreversible pulpitis, that's it. I mean, that's the end of the line for the tooth. It needs a root canal if it's even possible, right?
Yeah, and basically, maybe the terminology is wrong. Not saying that it's not a very easy terminology. It's reversible. We don't have to do it. If it's irreversible, we have to do it. But if it would have a different name and wouldn't have the name irreversible, that it's one-way street, we might think different. But let's be honest, it's very easy diagnostic tool to say, that's the street we take here, that's the street we take there, and it's fine. And basically, I did some endodontic continuous indication, and I met Martin Trope, who basically showed us a really nice study from a guy called Mr. Bogan from the US, an endodontist, who basically treated young molars of young children, basically, with full removal of decay. He called it direct pulp capping with MTA, but basically when I look at the clinical picture, it was basically a partial pulpotomy because he really removed all the decay, nicked the pulp a couple of times, just placed MTA on it, and it worked. And the thing is, okay, it's one study, let's see, but his recall rate was 97%. Yeah, it's like enormous. Martin Trope was joking that a private detective was hired to get this recall rate. and I unfortunately, Georg Benjamin couldn't attend the last German Endodontic Society meeting due to some restrictions because I wanted to ask him that. But with these results in mind, I kind of started in a different office where it had a more endodontic focus to treat these cases. And I remember one case where basically everything went wrong, Jess. Yeah, seriously, everything. Yeah, it was a deep cavity. I saw it on the X-ray before. I basically knew that some partial pulpotomy is better than a direct pulp cap due to the literature which is out there on these topics. And I did a partial pulpotomy, placed the MTA.
Before you progress with this course, let's paint a picture. How old was the patient and what was your pulpal diagnosis before you started?
Yeah, basically the patient was maybe in the mid-30s, an adult. My diagnosis was basically in reversible pulpitis because the patient didn't have any pain. And
I want clarity, reversible or irreversible? I couldn't hear it.
It was reversible pulpitis. Yeah.
Reversible, okay.
We just imagine you see deep carious close to the pulp and you'd be like, okay, the tooth is vital. The patient doesn't have a lot of pain, but we need to treat that tooth, that's pretty sure. And I basically entered the tooth, did a partial pulpotomy, placed my MTA. And back then, I basically had a two-step approach where I first placed the MTA, did a temporary filling, and recalled the patient to see if the MTA has set. And when I was placing the temporary filling, which was cavit at this time, I basically suddenly saw how the blood from the pulp came out. And I will say, okay, this will not gonna work at all because I'm out of time. I can't do anything anymore. It is how it is. And maybe she will be there for as a pain patient the next day. But she didn't come at us all. And if the patient doesn't come up, you basically already know what happens. He went somewhere else, in Berlin at least. But yes. Basically, the patient came back, I think, a month later because the temporary filling fell off. And basically, the MTA on it was hard. And since it was a partial pulpotomy, I could do my cold test. And the tooth reacted normal. And I just placed my composite on it, and that's it. And then I kind of realized maybe I didn't trust the pulp too much things. Yeah.
You didn't have faith.
I didn't have faith at all in the pulp. I mean, I kind of
like most of us, right? If you expose, especially if it's carious, like you're going to think, okay, Mrs. Smith, you need to have a root canal treatment for sure. So I don't think that's surprising. I think most of us would. I think there's a real paradigm shift for us.
Yeah, it's a paradigm shift, and actually now there's new literature out of which it makes it easier. Back then, it was 8 years ago. This is how we noticed that we are actually old, Jess. Yeah, but back then, whenever you had such a treatment, you should always say it was a reversible pulpitis because it still wasn't really allowed in an irreversible way, kind of, But the interesting part is actually there's this term called vital pulp therapy. And it's actually sometimes a bit misleading because vital pulp therapy could mean anything. It could mean an indirect pulp cap, a direct pulp cap, a partial pulpotomy, a full pulpotomy. At the last ESE meeting, I even learned the term mini pulpotomy, which is interesting. But I like this term. It's from a British guy. I forgot who. Sorry. Yeah. And basically, I'll focus pretty much on the pulpotomy part because it's the more interesting part.
Okay. Before you get to that, George, I just want to cast back to that case that you mentioned, that lady who you had this positive experience where you thought that, okay, she's going to come back in pain or it's going to go necrotic, and it was fine. 8 years on now, do you still see this lady? Have you seen her? Is everything still okay?
Actually, with this woman, I didn't saw her again. I saw her husband, but she also had like a really bad root canal treated teeth, which needed retreatment. And she didn't like my fee behind it. So she never came back. But I know that she was fine for quite some years. But I started recalling and documented these cases after that, actually, because it has gotten a bit more interesting.
Mm-hmm. And with that case, for the younger dentist listening, and for everyone actually, when you had that deep caries, which you knew was close to the pulp, but your diagnosis was that, it was still reversible pulpitis at that stage. There wasn't signs of deep throbbing pain, keeping her awake at night, nothing like that. Why did you not consider just removing as much caries as possible, but leaving some caries over the pulp and just restoring like that? Do you not think that perhaps dentine could have been the best insulator, the best base in that case, the best lining, if you like?
Oh, you're touching a really topic which I feel really strongly about it. I would like to put it in the end of the podcast because...
We'll find out. Stay tuned until the end. We find out why George prefers to actually go into the pulp in that case and do a pulpotomy, which leads us nicely to what you were just going to explain.
So let's focus a bit on the pulpotomy part because it's quite interesting. First of all, basically, pulpotomy basically started more or less in traumatized tooth, and therefore there's a lot of really good literature about pulpotomy in permanent tooth. You just say there's a chipped central incisor, the pulp is exposed, and we basically know from literature, even if this young patient is running around with this open tooth for a week or so, but we just need to remove 2 millimeters of the vital pulp, and it still will work. Yeah, which is surprising because the pulp has an immune system and therefore it fights. Of course, there are probably cases where it doesn't work, but Zweck showed it in animal studies that it worked, and even later on with his patients, and which is interesting. And this pulpotomy has a high success rate, but let's be honest, it's all young patients, all traumatized teeth, no carious. Of course, it works very good. So what's with the teeth we see in our office? And it's interesting. There's a study from Iran, actually, that they did a multicentral study with full pulpotomy in permanent teeth and compared it to a root canal treatment. And actually, the results were comparable. Yeah, but we have to be careful when reading the study because you can also always make studies and kind of get the same result if you don't read them well. And I've never been to university and of course I've been to university. I've never worked at university. I'm really not good in literature. So it's the first time I didn't see it. But actually in this study, which was quite good, the ICT group just was rinsed with sterile water. And in vital cases, it probably works, but not as good as maybe a stronger disinfectant like sodium hypochlorite. So the results are pretty much the same.
So for the actual root canal therapy, prior to the obturation for this RCT group, they chose to use sterile water in the study.
That's it. Yeah.
But why? We know, let's talk. That's not even the gold standard. We know that, so we should be using sodium hypochlorite. So why would you do that for a study? Surely that's negligent.
Yeah, you could sue it. I wouldn't go so far. It's negligent. Maybe they wanted to have the RCT group to be a bit less successful, but they both more or less got 80% success. And which is actually 80% success if you just look at the vital pulp therapy group. Multicentric, a lot of different dentists. It's quite good, actually. When you look at the molar, it's much easier to do a full pulpotomy and a molar, place some MTA, and restore the tooth right away than to do a root canal treatment. But I always have to advocate, if people are now saying, well, it's an alternative to an RCT. No, it's a more predictable pulp cap. I would say the pulpotomy is more predictable than a pulp cap. But let's be honest. A lot of people out there, and I have done the same, came from the university, done a pulp cap, and it went horribly wrong. But the patient
just for a student listening, young dentists, By pulp cap, just recap. Direct pulp cap, indirect pulp cap. What is the difference? Just describe what kind of materials you would use in each scenario.
Let's say you just removed an old insufficient restoration, maybe an old GIC, amalgam, whatever, and you can accidentally see that there's an open pulp, or maybe you nicked it. And basically, in this case, I would just like use calcium silicate cement. It could be an MTA, could be biodentin, could be whatever, and rinse it a bit with sodium hypochlorite. Usually I use 2%. Some people suggest 3%. Some say I always use 5% because it's the only thing I have to offer. Doesn't matter in my eyes. And basically, if it's like doesn't had a lot of symptoms before, it probably is fine. Yeah, I probably there's even
and that's a direct pulp cap, right? That's a direct pulp cap.
Yeah.
And then you know what? When I trained, we were using dical.
Yeah, actually, dical is actually quite bad idea because
of course.
There's literature out there that dical, CareLife, self-setting calcium hydroxide products work less successful than freshly mixed calcium hydroxide. And it's quite surprising that I was taught that in university because already back then everybody should know it from literature. And basically, it's better to use a freshly mixed calcium hydroxide and to place it on the pulp. If you're common with it, I basically use MTA because due to my endodontic background or endodontic savviness, I think it's cooler, kind of. But if you look in the literature, they both work great. Maybe the calcium hydroxide resolves. Yeah, we see sometimes old pulp caps, but the pulp is still vital. And sometimes in this scenario with the direct pulp cap, I tend to avoid it by doing something I would now learn that the term exists called mini pulpotomy. Because before I come to the mini pulpotomy, because I noticed I did some pulp caps with really cool materials. They're called bioceramics and everything, and they still went wrong. And I noticed that sometimes, even if it's just a small pulp exposure, and the bleeding stops by itself, which is basically by the book the best indication
it's a good sign.
Yeah, it's a good sign. Actually, I now, with my experience in vital pulpotomy or pulpotomy, I rather see the pulp bleeding. Yeah, and rather look for it. I would just like freshen up it with a diamond burr at high speed. Just don't remove anything. Just touch it 2-3 times. See, okay, it's really bleeding. Because I noticed sometimes that there's some blood in the pulp chamber, which kind of finds its way, but when it stops, when you open it, you really don't see a lot of really nice pulp tissue. And remember that story when I come back to the decay part. But first, I hope I don't jump around too much. The indirect pulp cap.
Yes.
I also already told you at this podcast that I like to remove all the decay. Yeah. Yeah. Even if there's now a Cochrane review which basically states that I'm basically dentine barbarian who removes too much dentine, that's fine. Yeah. In cases where I have deep carious, yeah, and I really thought I would expose the pulps, but I don't. Even if I removed everything, sandblasted everything, then I would do following. Still use sodium hypochlorite, like to clean something. Yeah, because
so you're basically cleaning the cavity, even though you don't have exposure.
Yeah, we clean the cavity because there's one study from Michael Sander who basically did that, and even in an indirect pulp cap, the success rate was much better than without. Yeah, which was interesting. In my logic, it's quite logic. And then I would just place again calcium silicate cement. In this case, go pretty fast to the biodentin. Just cover the dentine close to the pulp, not everything. And basically cover it with a self-etching flow because I'm really lazy. I don't really like to wait for the biodentin to set. In my hands, it works very good. Some people like to wait the 12 minutes until it sets. That's fine. Some people even do it in 2 visits, which is fine, and do a cutback. It's really, for this indication, the material is really a good choice. And that's it for indirect pulp cap. Yeah. Let's now go to the real pulpotomy part. And now the interesting part, that you have someone coming to you, could be a young patient, old patient, with a big decay. And of course, he has pain, maybe even at night. And I always say, of course, he has pain. I mean, if you have like Swiss cheese very close to the pulp and you feel everything, of course, the pulp is irritated. And the question is always, how much is the pulp irritated? So Of course, I do my pulp testing. I do an X-ray to kind of see if there's no lesion on the X-ray. Although we have to kind of say if there's a huge lesion, we probably say that's a necrotic, and our cold test was basically a false positive. But if there's like really, really tiny one, I wouldn't give it too much of a thought, actually. Yeah.
CBCT maybe, if you're in doubt, would you consider that?
I have a CBTC. Actually, in this case, I wouldn't consider it because now I strongly believe in the vital pulp therapy now, and I'm confident that I handle this. For the root canal treatment, I really like to consider it, but it's a case-by-case decision. But in the past, I went more and more for the pro CBTC because it gives me a lot of information I need. But for example, usually these cases, you see maybe something on one root, which is like a little enlargement, not a real lesion. And when you kind of take out your measuring tool and measure, is it more than 1/2 millimeter? Because if it's more 1/2 millimeter, don't cite me with that. It's probably more likely to be a lesion. If it's less 1/2 millimeter, it's probably not a lesion. Yeah, that's a rule of thumb I heard somewhere. I can't credit anyone, but it was a great tip I got. Yeah. But in this vital case, I usually would, if I would do the CBTC in these cases, I probably would expect that I don't see a lot of it. So since I wouldn't probably not do a root canal treatment, since I don't see anything, it doesn't really bring anyone a benefit. Yeah. But remember just the case, and everybody who's a dentist knows it, this one will be endo for sure, because it's such a big carious. And I don't have to point out if it's molar, premolar, whatever. You just know that feeling. And in some cases, even you think about which post I'm going to place or whatever. Yeah. And it's interesting when you enter these cases, these really deep carious we see in the dental practice, I consider my first choice of treatment is always a full pulpotomy. Yeah, if it's really, even if it's pain, we don't bother around with partial pulpotomy due to pain management reasons, actually. Because, of course, if you would be a patient and you accidentally would have like a hidden carious nobody saw with all the technique we had, I would probably consider in your case a partial pulpotomy, knowing that we have a full pulpotomy as the second option as well. Yeah, because you're a patient which is a dentist and we both know what we're doing. But
one thing before you then maybe continue is coming on to the difference between the mini, the partial, and the full pulpotomy within the, it seems like, for me, the pulp chamber in a molar sometimes is very, very small. So, I mean, what is really in millimeters the difference between and the protocol, I guess, between a mini, a partial, and a full? For me, it's just you're tickling the pulp chamber, you're going to make it bleed, and then you're going to put your MTA on top. So I'm surprised that there's 3 classifications of nicking the pulp chamber.
Actually, there's a really interesting German PhD thesis that she even found more. But let's say the mini pulpotomy is really easy. You just have a pulp, you just push the burrs really gently on it, and it starts.
How big of a burr? Because this is important. You know how they used to say, like, if it's like a 1/2 millimeter exposure or etc.
Okay. Yeah, okay. I know what you mean. Basically, I have Comet burr, which is a ball, which is a really long shaft. And basically, it's I think, a millimeter in diameter. And I have also a burkhead, which one is always sterilized for this kind of process because I just don't want to use the burr I just used for excavation. Therefore, I have a sterile kit I take out. You can argue that it probably doesn't matter, but that's a different discussion. And with that, I would do a mini pulpotomy and a partial pulpotomy. Yeah. And by partial, my idea is to take 2 millimeters away. But now it really depends in a molar, for example, from which angle do you look at? From the occlusal or from the lateral? Yeah. And from the lateral, it's quite hard to distinguish sometimes. And there's an interesting study about pulp caps, about pulp breaks on the occlusal and pulp caps on the lateral. And of course, the occlusal work better. And I would say we probably can transfer this knowledge to the pulpotomy as well. But it's harder to do a partial pulpotomy if you just nick a pulp horn and kind of remove it. And so you don't know, did I do a full pulpotomy on one root of this molar and the partial pulpotomy of the other one? And to make it short, if in doubt, go for pulpotomy. What is full pulpotomy? You just go until the root canal entries. Yeah,
like the orifice, literally like the canal orifice.
Yeah, pretty much. that's the full pulpotomy. You basically take the whole pulp chamber away, and actually it's sometimes makes bleeding control quite easier than a partial pulpotomy, because you just have some root canal orifices where it's bleeding, and you can kind of just use your sodium hypochlorite, which is my first choice. Sometimes I even use sterilized foam pellets to put some gentle pressure. And
one thing that maybe someone may not appreciate, and I'm just thinking out loud here, is if you're trying to stay within the pulp chamber and not actually damage the pulp tissue in the canals, it's fair to say that with your hypochlorite, you're definitely making sure that you're definitely staying within the pulp tissue. You're not forcing any hypochlorite into the canals. Okay. Is that an important part of the protocol?
Actually, it's important that we don't put our syringe like an endodontic treatment and place it directly into the canals. But actually, it's a typical question you're pointing out, Jazz, because a lot of people are afraid, will the sodium hypochlorite destroy the pulp? And basically just say, did you ever get sodium hypochlorite on your skin? Yeah. And the question is, some say yes, some. What happened? Well, it burned a bit, but did it went through your arm? No. And actually, in a lower concentration, it used to be in the First World War as disinfection agent for open wounds. So, of course, the sodium hypochlorite can dissolve necrotic and vital tissues, but that's good news. It's basically doing parts of your pulpotomy for you, but in a chemical way. And that's why it's like the best thing you have there. And now we have to talk about the bleeding time, because that's the most obvious question when it comes after that. And it's really interesting when you look at the literature, and we have now recommendations from the German Endodontic Society, from the ESE, and it's great what we have now. For example, Domenico Ricucci waits 2 minutes, and then he goes on with his partial pulpotomy, waits 2 minutes again until he reaches the full pulpotomy. Yeah? But Domenico Ricucci is a really great dentist. I admire him, but he has a lot of time and patience.
Yeah. But what are you waiting for? Like, so you enter the pulp chamber and then you just wait 2 minutes to let it bleed out?
Yeah, basically you place your sodium hypochlorite and wait for the bleeding to stop, basically. Actually, in the ESE paper, you're allowed to wait for 5 minutes. For example, you first do a partial pulpotomy, wait 5 minutes, the bleeding is still there. Then you do a full pulpotomy, wait 5 minutes. And if it's still bleeding too hard, you basically go for a root canal treatment. And that's actually a recommendation which is for every general practitioner out there quite good. But we have to think that it's just a recommendation. It's not a law. There's no science supporting this bleeding time. And of course, there will be now someone on university in the endodontic department who wants to kill me for that statement, but that's fine. Actually, I love having discussion with my German endodontic department, because I say, and I have some minor literature to prove it, that the bleeding time doesn't really matter. But that's just my scienced opinion. But it's okay to go with that. Because I noticed that sometimes there are also other bleeding control agents out there which don't have any science on them, so I don't mention that. But if we just look at milk teeth, they basically use ferric sulfate and works great. Yeah. Could you use ferric sulfate in a permanent molar? Yeah, probably you can. Is there science on it? No. Pretty easy. So it basically comes to guessing. And some people are afraid that we are hiding some symptoms which are inside the pulp and which cause pain. But let's be honest. If the patient still has pain after full pulpotomy, you do a root canal treatment. Yeah. And that's it. Yeah. Did you lose anything? No. You have a nice pre-endodontic build-act probably. Is it hard to drill through MTA? No, it's quite easy, because MTA is like the underfilling onto an amalgam. You really say, yes, great. It's so easy to remove. It's not a tooth-colored composite or a GAC, which is tooth. It's so easy to remove. So go for it.
But a real-world issue here, George, is fee discussing. You know, setting your fees for the patient and extra time that's going to take to then need that, and then you need to have a patient on board that, okay, we're trying this. If it doesn't work, then you need to pay for the root canal treatment, and then it just needs an additional procedure. And having a patient on board that, you know, had you just had the root canal treatment, you'd be out of pain. Now, it's a shame that you don't have a pulp anymore, but we've been doing it for many years.
Okay, I know what you mean. Actually, at the beginning, it's quite easy. You just present 2 plans. One is pulpotomy, one is root canal treatment. We don't know yet what will happen. If you have time to plan that, you say pulpotomy is 1 appointment, therefore it's just maybe half the price, and root canal treatment is 2 appointments, so it's double the price. It's logic, yeah. And basically, the people are quasi always on your side if you say we try to avoid root canal treatment. Although I don't like it. Yeah, I told you that. I don't like it to point it out as an alternative to root canal treatment. But for example, it could be a false positive, so there's no pulp inside, it's just necrotic. Of course, you have to do a root canal. Pretty easy. Yeah. Mm-hmm. And so for the beginning, it's actually quite good to do it. Actually, in Germany, we have the problem that our health insurance billing system doesn't really have this pulpotomy position for permanent teeth. For milk teeth, it has. So it's kind of, you have to be a bit creative, unfortunately, in that
we know what that likes in the UK. We know how to be creative in our systems.
Yeah. And but basically how it works. Yeah, just because you're from the UK, Jess. So a guy from the UK said also at the EC meeting, he waits for 10 minutes.
Oh my goodness. Okay, he must have been a private endodontist, not a health board. Yeah, nothing insurance based there. So that makes sense. I mean, there's so many questions going on my mind now. So you've described the mini pulpotomy. You just sink the burr through a little bit, let's say 1 millimeter. Partial is up to 2 millimeters that you go into the pulp chamber, and full is you reach the canal orifice. One thing I want to know now is how still that decision making. So what I'm hearing, I guess, George, for you is that irreversible pulpitis. I've been awake all night in pain. I need to put a cold bottle next to my tooth to get out of pain. That classic irreversible pulpitis. You're suggesting to me that you will still try to assess the bleeding time and potentially go down the route of pulpotomy in this day and age, 2022, Qatar World Cup coming up, and you're saying that now you've shifted away from, okay, this tooth needs RCT to, actually, I'm going to go for pulpotomy. Am I hearing you right?
Yes, but there's also a little but. For example...
Let's hear the nuances.
Yeah, the nuances. For example, if you now have a businessman who will be at the World Cup in Qatar next week, it's a different patient management in this case. Yeah? I would say, look, I strongly believe this will work, but it could be that the emergency dentist in Qatar says that I'm the worst dentist of the planet because I started a RCT and did not finish it. Yeah. Mm-hmm. So, and it really depends on, for example, now I more or less don't have my own patients anymore. I rather get referrals. So it makes it a bit more complicated as well. So if, let's say, the next 14 days he's in town and would be fine, if there's something, I would probably go for full pulpotomy. The younger they are, I tend to more say pulpotomy is my first and only choice because it just makes sense in my eyes. Because I did a lot of retreatment of teeth, broken canals, broken instruments, and I know how many things can go wrong. And even I break even instruments, of course. Yeah. So it's from my logic, my first choice. And if you have your first patients where you're doing it, always do a full pulpotomy. Dentists always want to do a partial pulpotomy in their first case, always do a full pulpotomy. Just trust me. Yeah, I know. I talked to really cool people like Nesrin Taha from Jordan who did research on it. And she even said, which is something scientific, the full pulpotomy tends to work clinically better than the partial one.
Then why not always do a full pulpotomy? It's only like 1 millimeter, 2 millimeters extra pulp tissue. Let's just go for it.
Yeah, I mean, the partial pulpotomy has some advantages. And one big advantage is that you can do a cold test later on to see if the tooth reacts to it. With a full pulpotomy, you can't do a cold test because the whole pulp chamber is full. And that's a really drawback. But I still say for your first case, guys, remember me saying that, go for a full pulpotomy. I know that there are people sending me X-ray. I did a partial because I was afraid. Okay, do a full pulpotomy for your case first, then get experience, and that's fine.
All I'm thinking, George, is the next time your uncle, your brother, your father, your mother, your nurse, your receptionist, your neighbor has signs of irreversible pulpitis or that very deep caries that you just know it's going to be an issue, then perhaps your first full pulpotomy should be on this kind of patient.
Yeah, and actually, right now, I wouldn't have any problems to do it on any family member, on any staff member, to do a full pulpotomy, because I now have the confidence. But we talk about failures as well, because without talking about failures, it would be very misleading, this podcast. Yeah?
Yes.
And
yes.
basically, you can distinguish it between early and late failures. Yeah. First of all, how high is the possibility that the patient will be there on the next day and still have pain? I can tell you that the pulpotomy as a pain treatment works in 91%. Whereas a pulpectomy will work at 99%. And from the emergency dentist point of view, and you had it in your podcast recently, I think.
Yes, we did. Yeah,
I listened to
Sanj
that.
Banderi, yes.
Yeah, it was a great
I'm
one.
sure you would have done, yeah.
Yeah, and for this 8% more success, how much time do you spend? So I can tell you that it's pretty much less likely that the patient will show up the next day and have pain.
So the lesson there really is if your main occupation is an emergency dentist who does not have the privilege and the pleasure of following up your patients, and you're delivering a service, and that service is get this patient out of pain and keep them out of pain, then perhaps in your setting, in your environment, you should stick to pulpectomy. Is that a fair statement?
Depends how many patients are in the waiting room. I mean, actually, it's only during the corona pandemic, Yassan Garrett even suggested from his time in Lebanon to just place dexamethasone, just do injection with dexamethasone close to the pulp, just do an infiltration, that's the best word, and it will resolve the pain. Yeah,
so like intrapulpal.
No, not intrapulpal, just like a regular anesthesia.
Like a buccal infiltration.
Yeah,
like
buccal infiltration.
Oh,
yeah.
Okay.
Yeah, and he suggested that they did that back when I was in Lebanon, and maybe now at the beginning of the corona crisis, everybody was afraid of the aerosols. That should be a treatment option we got considered. Yeah. So if you have really a lot of patients, you basically have to take the one with the pus coming out. He's your first choice. The other one can get injection. If you have a lot of patients, more or less no severe swellings, I would go to full pulpotomy with everyone and just place some temporary filling on it, and it will work quite good. And of course, if we have these cases where the bleeding is so extensive from the canals, no matter what you do, it won't stop. These cases, you do a pulpectomy, of course, yeah, because you can't really tell them, even in an emergency center, that bleeding out of the tooth is normal.
But well, it's true. But early failure, you said, was the next day, pulpectomy, 99% out of pain. Pulpotomy, 91% out of pain. And then so if someone comes in with an early failure, does that then mean they now advance to stage 2, which is the pulpectomy? Is that what
basically
happens?
after full pulpotomy, it's pulpectomy. It's pretty easy. Actually, interesting, with my failures, it's actually, I have a gender part in it. A lot of more female patients have an early failure. Yeah, which is interesting. And usually the early failure is in the first 7 days. Yeah, even like now tennis to hot drinks or still cold. After full pulpotomy, if you feel something cold, there's something wrong, you can basically say. Okay, maybe there's a really recession at the palatal root, and where you can kind of get some signals of it that could explain it. But after full pulpotomy, they don't feel any cold. And so if they still feel something, it's kind of odd. Yeah. And really, I would say in the first 7 days, it can happen. Yeah. Okay. Remember the 80% success from the Iran study. And I think we can relate for that very good. But it's not like that every 5th patient will visit you next week and have pain. Because we have also late failures that somehow tooth get necrotic, or basically they get necrotic somehow.
Well, the interesting thing here and the dilemma we have is that if we start in the future, because look, George, as much as we'd love for everyone to do pulpotomy, and I think this episode is going to go a long way, hopefully, to start making dentists think about this. And so that's what I love about speaking to people like you, generating new ideas, not even very new, like relatively new, because we know the literature is now getting out there, which is amazing, and we're sharing these new protocols and ideas. But the dilemmas it poses are also new, which is the whole thing about cuspal coverage. If the patient now needs to spend an additional, I don't know, 900, £1,000, €1,000, because to be able to get to a point where the tooth potentially needs a pulpotomy, it's the same thing as it potentially needs pulpectomy. It's got a huge amalgam, a fracture, it needs cuspal coverage. And then the extra dimension of doubt that you have now is, should I put a crown on? What if 2 years later we have to then drill through the crown and do an RCT, which is the same dilemma we have when we have deep caries, right? So this is another layer of complexity.
Yeah, but in my hands, actually, the pulpotomy makes things more simple, because we don't have now the guessing. Is there was the leaving the decay okay? How was the pulp studies anyway? We don't know that, yeah? And with the pulpotomy, we have one advantage. We saw, was it vital? Was it necrotic? Or did it look well? Actually, it's really hard. There's not a really good book about how the healthy pulp and a lot of picture of healthy and unhealthy pulps, which it really comes down to experience. And I even myself say something, is it? Yeah. And for example, you just mentioned your staff member. I just had a staff member, opened up the pulp, and there was a small moment where I said, okay, I just expose the pulp a bit. I just do a mini pulpy and will be done. It will be great. But it was like, no, she had pain. I go for pulpotomy, and I looked at the pulp, and you could see the pulp. It was not really bleeding very good. So I did a full pulpotomy. It still was not bleeding very hard. I saw some bleeding and was like, oh, okay. Yeah. I still went for the biodentine on top, placed my filling, but said, okay, let's look. Yeah. Next 7 days. And the 7 days are over. She still have some symptoms on hot. So I say, no, we have to probably do reversity. It's pretty sure after 7 days. If the pain is not gone after 7 days, it's a quite good sign. Mm-hmm. I mean, she has a short distance to the dentist when she is at work and experience pain. So
when the next patient cancels, she's the one in the chair.
No, it's usually the last patient of the day or something like that. Yeah, we always find a way. And therefore, when you kind of have a look at the pulp and you kind of still don't feel really comfortable, it's probably not working.
What does an unhealthy pulp look like? Like a vital but unhealthy pulp that gives you that feeling in your stomach that it's not going to work? For the less experienced, because look, think about it, George. We are used to living way less experienced than you. We are used to opening up the pulp chamber with one motive. Kill, kill, kill. We don't even probably look at it. We just go through the bleeding. We just stick some hypochlorite right in the canal and we put the pressure inside. We don't even pause and say, what is the health status? What is this pulp looking like today? So you need to enlighten us.
Yeah, it's very difficult to tell that. And even when I look at Dominic Ricucci's studies where he did a lot of pictures of really nice pulp and he says, that's unhealthy, that's healthy. I'm like, oh, wow. Yeah. And there are some things where you can say the color matters. If it's really pinkish and it's probably, if it's more brownish or leathery, let's say this way, it's probably not very. And sometimes, I mean, you can just probe the pulp and if it feels like it's one block or very liquid, it's probably not working. And I even had one case where I wanted to do kind of some pulpotomy at a central incisor and just rinsed it a bit. And suddenly the whole pulp was in the vacuum. It was sucked away. And I was like, okay, probably that was not a healthy pulp. Pretty easy. But I also had the case with a young patient where I had on the referral sheet root canal treatment till 3002. And I looked inside and it was a healthy pulp. Apparently the pulp kind of went away and didn't want to be poked by the file, which was interesting. And so I don't have the answer for you, unfortunately. Yeah. But my answer is, I like a bleeding pulp. If it's bleeding and it stops, it's a good indication.
What if it's that term, hyperemic? We always see the patient in pain comes in and it's just flooding in blood. Is that encouraging for you as someone who's now looking at it as a pulpotomy?
Yeah, let's say this way. If it's really hyperemic, you probably have no chance because you would need a really strong bleeding control agent or even something where you just close your eyes, place MTA on it, cover it all. It's probably not going to work. I wouldn't say never, but it's not that I
so it's just good to know that if it's too much bleeding, it's hyperemic, that's go with your gut, and then that is an unhealthy pulp.
I think that's why I basically like the time with the 5 minutes, which is basically, I don't want to say it's in the literature, you have to stick to it because some people are very dogmatic about what's in the literature. It's a recommendation without any proof. But I like it, and I would say if it's still bleeding very hard after 5 minutes and you left sodium hypochlorite on it, it's probably your restorative material will not work. Yeah, but I also found that some MTAs work better than the other, which is interesting. And since people are always asking me for products, Biodentine has the best literature from Zeptodont out there, so it's my first choice. When I have, for example, a really young kid, where the bleeding, it's a little bitchy, yeah. That's the best way to describe it. But I still want to keep it. I sometimes tend to use material from Circamed. It's a Polish company, BioMTA Plus because it's bit better.
That's a cool name, BioMTA Plus. That's taking every single good thing in endodontics, BioMTA and Plus, and just that's the best product name there is in endodontics, surely.
Sacamate is a nice company. We're not good at research, but this material...
the real wet fingers dentists of the world.
Basically, it's was founded by wet finger dentists. But it works good in situations where the pulpal bleeding is a bit bitchy. There are other materials which are also very interesting because Ultradent just released MTA Flow White, and the material has like an agent in the liquid which is less problematic when washing away and wash away fluid.
So less water soluble.
Yeah, who knows? Actually, Josette Camilleri told me that it's something which is very, very common in the concrete industry, but only 2 people in the dental industry have it in their products. Then there's also products from Angulus, MTA Repair HP. It's also quite good. And I tell you why it's important that we have some different materials, because we didn't talk about one thing, which is tooth discoloration. Because some MTAs, even the classical Pro-Root MTA, have some radiopaque inside, which, when it's combined with sodium hypochlorite, discolors. And they have different concentration. For example, the Sacamate one has also this radiopaque in there. So I would rather use it at the molar and tell the patient that the tooth might discolor. It won't turn black, don't worry, but it will appear more grayish. And if it's a first premolar, you'll see that. And then we also have to take in consideration that in every manual you take out in Baridentine, that they say only place it on basically on the non-bleeding pulp. And the reason is when materials come in contact with blood, which are supposedly not discoloring. Of course, if there's too much blood with this iron inside, it will discolor. It's very natural. So that's also a reason to spend a bit more time in controlling the pulp, and that's why the pulpal bleeding. And that's why I'm not a fan of this 5 minutes in that situation.
Well, we have to now wrap up and talk about, okay, why is it that you're so anti leaving some caries where you can get a good bond because your peripheral seal will be good. The seal is a deal and Edwina Kid. So why not leave carious dentine as your base?
I mean, I'll try to make it short. Basically, the concept is very good, and I liked it at the beginning a lot and did it a lot, even with this deep carious one. And I got failures where I would say I rather would have done a pulpotomy. With this peripheral seal zone, it's a good idea, but let's be honest, if you think about it, that the sealing sounds better than it is. Even like a healthy tooth, bacteria is crossing it the whole time. It's not sealed in the way because we don't have a sterile environment in the mouth. And basically the carious model everyone is talking about is maybe this flower model with if you take away the nutrition, and then nothing will happen.
It's a disease of the surface, as you said.
And it's a simplified model, and it's really easy to understand, and it's completely okay. But you have to always say it's a simplified model. Who says that there are not some bugs in the decay who don't need sugar? They just live on pulpal fluid. So these bugs, it's really simplified now. I myself doing the same thing, but I have a friend, Tilda Maschke from the University of Münster, Germany, who can say it in a much more convenient way. Actually, we have a German podcast on it. The seal is not the deal. But
very good.
But he basically says there are some bacteria who are irritating the pulp. And, Falk Schwenniken, one of the advisors of the seal is the deal theory, which he's done great research, says, come on, it's just, of course the pulp is irritated. What's the deal about it? But I would say, clinically speaking, I tried it. In some cases, I'd even still do it. For example, in cases where you have a lower mosal and a really cervical dentine carious right in the distal, where if I would do it directly, I would destroy a lot of tooth. In these cases, I would just try to push some GIC inside and monitor it. And of course, there are some patients where it makes sense to use this approach, but it really also depends on your personal setting where you work in. And for example, if I have the time, if I have rubber dam, magnification, of course I can remove more and look if there's a pulp. And with the success rate of the vital pulp treatment of the pulpotomy, which is so good, I would even say
that's 80%, right? We're talking about 80%, right?
80%. Actually, 80 is, if you look at the literature, it's the lowest.
And how many years are we talking? 5 years, 10 years? What do we have?
We don't have 10 years. We have 5-year max. That's a pity, basically. And that's why now the Cochrane reviews favors leaving of the decay. I say it on purpose, leaving of the decay. Yeah. And anyways, if you have like in a rural area where not a lot of dentists, it's a good concept. Let's be honest. And the whole technique with children, really good concept. Yeah. Let's be honest. Yeah. But the success rate of this treatment after the Bjorndal study, whatever, it's not so good if you just look at the numbers. It's maybe 60%. Yeah, okay, we've had really strict success criteria. If it's not reacting on the cold test anymore, they basically said that's a failure. It's really strict. But if you look at other studies, newer studies from Nesring-Taher, we're in the 90% area with the success rate. Yeah, and we don't have
vital pulpotomy once again. Yeah,
vital pulpotomy, irreversible pulpitis, everything you want, permanent teeth.
Wow.
Yeah, and that's a lot. And then you basically think Lars Bjorndal had 11% success with partial pulpotomy, and you basically ask yourself, what did they do wrong? And it's not written in the study. Yeah, and it's not a criticism. I mean, it's a great study, and the evidence much higher than everything else, but we don't have any comparison studies. And of course, everybody in university say, "Oh, just do a randomized trial." Okay, I don't know how to do a randomized trial. It's kind of even like when you think about it, I would like to do a randomized trial, but I don't believe in selective carious removal. So I should do something I'm not believing in. Guess the results. Probably it will turn out better than my vital pulpotomy. And that's something because I'm just biased. And even with like a lot of centers, you will get basically this result. Either one is trained in the vital pulp therapy or in the selective carious removal. And I don't condemn myself, but I, for myself, from my experience with my failures in vital pulpotomy and selective carious removal, decided I don't want to do selective carious removal anymore. And I hope I am not will be like this, this old dentist like in the early days. We did removed all the carious and it works much better than your selective approach. And, I'm not sure about it. I'm not following up all my cases to really know how is my success rate. And my recall rate would be really bad. But that's a problem in all dentistry. And it really depends. Now I'm basically in private office. I have time to place my rubber dam treatment plan. Of course, it will work in my hands quite good. Yeah. And let's be honest, if I would believe in select cavity, these cases would all work very good as well. Yeah. So I don't like this dogmatic approach at all. There are some reasons to look at the pulp and see if it's vital. Like a surgeon. Like a surgeon. Just kidding. Yeah, but it's nothing I would say do that or that. But for us in the practice, and I worked in a rural ways, just remember the tooth with a deep carious, and it will be endo for sure, and I don't really have time. These are the good cases to start, because you don't have anything to lose. And it's not an experiment. I really hate the word experiment. Sometimes you're doing experiments. It's nothing new. It's probably even older than Zweck. I think even like before the First World War, some people were doing research on it, and it was just forgotten knowledge. I mean, even selective carious removal is nothing new. There's a really nice Swiss article about it from the 50s, where they extracted first molar of children and kind of compared selective carious removal with full carious removal, and they used in the full carious removal the new material calcium hydroxide back then, the MTA of that time, so 50. So it will come in waves. And just to conclude it, I'm not dogmatic of any way, and I would really be happy to see some literature. And I know in the Falk Schwennicke group in Berlin is working on it. I would say there's not a perfect study you can design to really convince everyone. due to the bias. And
I mean, yeah, clinical dentistry is plagued with this issue of not having amazing evidence when you compare to, other fields. So this is what we have to accept. So it's still a lot to be discovered in terms of what are the best definitive protocols. So I very much appreciate that. Let's not be dogmatic. And it's one of my favorite things. There's no place for dogmas on this podcast. And I thank you very much for giving your time to discuss this. You've opened my mind, George, because, to think that irreversible pulpitis does not equal RCT anymore, does not equal pulpectomy anymore, is very fascinating. And my background in training is never expose. That's just like ingrained in me, never expose. But really, and I'm open to listening to you and finding out more, which is in some cases, actually, there is a place for pulpotomy in the adult tooth, which has been carious and a dubious pulpal status. So I think what we've done is open everyone's mind. What do you think is the next step? Because I don't expect for intelligent dentists to listen to this one podcast episode and then just start cracking on and guessing how much MTA they need. I do feel that perhaps there's some training that's merited. Where does one get some training and some knowledge? And also one more thing actually is, if I'm working with an endodontist in the practice, and before I start sending him cases or advising him, you really need to have an endodontist who is on board with you, right? And I think that sort of team approach is really important, to have that open line of conversation with your endodontist.
Yeah, I was at the ESE. You don't find any endodontic conference from now on, probably till the next 10 years, which is not talking about vital pulpotomy. It's the hottest topic of this. No, I wouldn't say so, of this decade for sure, because now the AE had a position statement and the ESE, and basically we were just waiting for 10 years data, and there's like something like a little fight between the cariologist and the endodontist, and the cariologists will win because they're much more. That's fine. To get your endodontist on board is a really cool idea. Do not basically tell him you basically just do the root canal and he's just doing what is on the furrow sheet, because that's a different topic as well. Actually, I have an old lecture at dentinal tubules with Duchamp a couple of years ago. Actually, just when we started talking, I thought I really have to talk to Drew to update it, because some of the things I say, I would frame them differently now, which is fine. Yeah. And this is you see how it evolves. And I'm pretty sure there's training out there, but most of the time people think it's so specific, probably no one is interested. And actually, if you call it pulpotomy of permanent teeth, every dentist understands it. It sounds something new. And just start your cases, document them, and you can do some local lectures for sure.
Well, what I appreciate is we're not trying to make something more complex, because I'm not going to name any names here, George, but there are some subspecialties, let's call them, or disciplines, new disciplines of dentistry emerging, which I think are trying to complicate dentistry, and they're giving new names and new acronyms to things which just already on the old textbooks. I think you know what I mean. And I like the fact that you're going
biomimetic.
Fuck, man. Yes. Okay. And I've got so many biometric friends, and guys, like I don't mean any offense, right? They're great, and you guys, I love what you do, but when did we stop calling it adhesive dentistry and just change it to biomimetic? I don't know when that happens. But yeah, what you're doing, George, is I appreciate that you're saying that, oh no, it's not vital pulp therapy. Why don't we call it a pulpotomy of the adult teeth?
Yeah, pulpotomy of vital pulp. And one thing, biomimetic dentists are afraid of the pulp. I don't know why, but they're afraid. I would say that it's basically due to they're based in the US. They have to refer everything to the endodontist, and they lose money on it. That's just really a simplification.
Very cynical, but yes.
Yeah. Okay. Therefore, they want to tend to have anything inside, and then therefore this concept of selective caries removal works very good for me. I'm not afraid of the pulp. Not at all. You don't need to be. If you see the pulp, just refresh it a bit. If it's bleeding too hard, remove a bit more. If it's still bleeding too hard, remove the whole pulp chamber. And when you have RCT, or if you don't want to do RCT, just stop there after the full pulpotomy and place some Lilamex pellets. So the endodontist will love you for that. And the patient won't hate you because they're basically out of pain. So everything's fine. You don't need to be afraid of anything, of not exposing. And there's one German study where they exposed the pulp and they had really bad results. And when you look at the studies, the treatment was done by dental students. They used Curlev and Decal, things which don't work. Plus, they placed a temporary filling on it, a GIC, which is regularly a good material unless you have an exposed pulp. Then it will be a success after 6 months. And you basically can wait for it will be not a success, it will be failure after 6 months because the bugs are going downward and they're going to love to kill the open pulp. And that's pretty easy. So you find today literature for anything, but you don't need to be afraid of the pulp.
Guys, no longer are we afraid of the pulp. I certainly won't be. George, thanks so much for giving out time. Really appreciate it. Check out Surazan. I hope I said it correctly. We'll put the link on. And again, thank you so much. And good luck to Germany at Qatar. I'll be rooting. I'm cheering 3 teams. England, but today I paid £5 to in the sweepstake at work, and I got Argentina, and I paid another £5, and I got Spain. So my 3 teams are England, Argentina, Spain. And if I win £150, and I will treat the entire staff to pizza. So that's the plan.
That's a good plan.
Thank you so much. Well, there we have it, guys. Look, I'm really sorry if I offended anyone towards the end. I've got some really great friends who are biometric dentists, like Herman. Herman, I know you listen to this. Thank you so much. Look, you know I don't like to offend anyone, and I really mean it a bit tongue-in-cheek. I mean it as a jest. But what we're trying to say, what me and George meant was that sometimes we need to simplify things and not complicate it. And I think what George suggested was that biometric dentists are afraid of the pulp. We know that's not true. We know you're trying to preserve the pulp as much as possible, and I get it, and that's awesome. So love to all, respect to all. Let's listen to everyone, but do what feels right to you. So guys, don't just jump in and do a vital pulp therapy, aka pulpotomy. Maybe read a little bit more around the subject and then commit to it. But at least it's giving you a reason not to be afraid of the pulp anymore. Thank you so much for listening all the way to the end. Claim your 1 hour plus CPD by answering a few questions below if you're watching on Protrusive Premium. Thanks as ever for joining us today.